Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And this is our first episode of year 2022. So wish you all Happy New Year. And Maddie, how's your New Year celebrations?
It's been good. New Year itself was not very exciting because I finished nights that morning. So I was in bed by about 10 o'clock. It was not great, but I hope 2022 brings better things. How about you?
It was kind of quiet because I was working. But for those listeners who are listening to this podcast, Maddie has completed her fellowship and moving into the transitional fellow job next year. And she will be working on a consultant roster, so no more nights. So the message is once you finish your fellowship exam, the grass is much greener on the other side, I guess. Is that right, Maddie?
We hope so. I don't know. I haven't started the year yet, so we'll see. But starting my last set of nights tonight. So looking forward to no more nights, like you said.
That's right. So let's dive into today's episode. So we'll start with the first case. So Maddie, there is a 32-year-old female who is 28 weeks pregnant, and she has got a background history of asthma. Now, she has been admitted to hospital for last 4 days for management of hypertension. And now the rapid response call has been activated because she has become acutely breathless. So as a registrar or as a fellow walking towards this patient, what are the kind of key differential diagnoses come to your mind?
So I'd divide this up as diagnoses related to her pregnancy, to any exacerbation of chronic conditions, to some new acute pathology or iatrogenic causes. So in terms of related to her pregnancy, given that she's had hypertension, which is a spectrum in pregnancy, she could be suffering from preeclampsia and have pulmonary edema secondary to preeclampsia. She could have a pulmonary embolism as pregnancy is a procoagulant state. She could have aspirated as there's pregnancies associated with decreased esophageal sphincter tone. And she could have a metabolic acidosis, so be tachypneic as a compensatory mechanism from that. And that can be due to things like acute fatty liver of pregnancy or renal failure secondary to the preeclampsia. In terms of exacerbation of chronic conditions, we know that she has a background of asthma, so she could have had an acute exacerbation of this asthma. And this could be complicated by things like pneumothoraces. She could have pre-existing other respiratory or cardiac disease, but it's less likely in a 32-year-old female. And from new acute pathology, it could be drug-related, such as an allergic reaction or transfusion-related. She could have new sepsis with ARDS or a pneumonia. She could have pain from some other pathology, or it could be iatrogenic, like she could have had excess IV fluids during her stay, or could be on a magnesium infusion and have magnesium toxicity.
Thanks, Maddie. So that's a quite broad list of differential. So how would you perform your assessment in order to identify the cause of her deterioration?
So as with any assessment of a patient, it involves a targeted history, examination and investigations. In terms of history, this would involve thinking about or looking into her state prior to a hospital admission. So that would include her comorbidities, especially the asthma control. Has she had any hospitalizations for it before? Was she on preventers or steroids? Has there been any ICU admissions? And did she have any recent spirometry or lung function tests? Whether she's on any regular medications, allergies, or whether she smokes. And then looking at her trajectory in hospitals, such as how her hypertension has been controlled, the medication she's been having, any recent blood or end organ function, and history regarding her acute deterioration. So any associated symptoms such as fevers, any similar episodes, timeline, and whether there were any recent medications given. From an examination point of view, it would involve looking at ABCs, the vital signs, any signs of things like anaphylaxis, listening to her chest for wheeze or crepitations, and looking at her hemodynamic status, and a targeted systems review looking at, like, for example, her neurological systems, such as her mentation, whether there's any weakness or hyperreflexia, such as in magnesium toxicity, fevers for sepsis, calf pain or swelling for DVTs, and any abdominal tenderness for things like fatty liver. And then investigations can once again be divided into bedside, blood and imaging. So bedside tests would involve things like a blood gas, looking at her gas exchange, metabolic status, lactate and her sugar, a CTG looking at the baby's heart rate and well-being, an ECG looking for signs of right heart strain, tachycardia or any acute ischemic changes, and a UA for signs of infection or protein. Bloods mainly concentrate on end organ function, so UECs and CMP for renal function, magnesium level, and LFTs for liver function tests, a full blood count looking for a hemoglobin for signs of bleeding, platelets, which might be low in things like HELLP syndrome, and leukocytosis, which can be a sign of sepsis, but can also be normal in pregnancy. And depending on the preceding findings, considering things like septic screen, hemolysis screen, and a troponin, and imaging that needs more consideration. But things to think about would be things like lung ultrasound, a chest X-ray, a VQ scan, or a CTPA, but it will depend on the context and also factoring in the radiation associated.
Yeah, that's correct. So I guess the pregnant patient becoming acutely breathless can be quite concerning scenario, especially if you're attending this as a junior registrar or even as a senior registrar. Make sure that you got adequate help around you to deal with this scenario. Now, Maddie, in the history, it was mentioned that this patient also had a history of asthma. So what are the kind of considerations in managing asthma in pregnancy?
So I think the main thing is that prevention and minimization of asthma exacerbation is very important. So asthma is the most common chronic disease to affect pregnant women, and poorly controlled asthma and asthma exacerbations increase the risk of poor outcome for the fetus. So the goal of asthma management during pregnancy is to maintain the best possible control and to prevent any exacerbations. So general things would be to ensure there's adequate inhaler technique, avoiding exposure to any triggers such as cigarette smoke or allergens or environmental exposures, treat any exacerbating conditions such as rhinitis and reflux, and regular monitoring and follow-up. The approach to asthma control is a stepwise approach to treatment, like in the case of any non-pregnant adults. The risks of treatment are much less than the risk of acute exacerbation. So previously there has been worry that the drugs might have an impact on the fetus, but there's no strong evidence for that. So the stepwise approach involves the same thing we do for other adults, which include short-acting beta agonists for relievers, then inhaled corticosteroids or inhaled corticosteroid long-acting beta agonist combination. And we keep stepping up, increasing the dose of the inhaled corticosteroid and maybe adding oral corticosteroids, and then considering a long-acting muscarinic antagonist. Management of acute exacerbations is similar to the non-pregnant population, but I'll just mention some key difference. So in terms of the assessment, for the peak flow meter, the normal values of peak expiratory flow are not significantly altered by pregnancy. But in terms of blood gas, pregnant women get a compensated respiratory alkalosis in pregnancy. So the PaCO2 is usually around 30 with a bicarb of 20. So if you see a normal CO2, it actually might be a sign of severe compromise in the pregnant patient. So it's something to watch out for. And it's important to also think of fetal monitoring. So the best way at present is a CTG. Other things is to avoid maternal hypoxia, because that will help avoid fetal hypoxia. So we use supplemental oxygen and aim normal SATs of like 95% or more. Avoiding the supine position, especially post 20 weeks because of aortic cable compression. And generally, they'll have a lower threshold for ICU admission. And things to think about if it's severe asthma is for NIV, there's also it can help, but there's also a risk of increased gastric distension and aspiration. And if they do require intubation, it's often a difficult intubation due to airway edema, a decreased FRC, and increased oxygen consumption. So there's a decreased time to desaturation. There's also increased breast tissue and an increased risk of aspiration. In terms of the acute control for exacerbations, the medications are the same as for the non-pregnant population. So beta agonists inhaled, there's no evidence that inhaled beta agonists interfere with uterine contractions, and parenteral beta agonists are rarely needed, but sometimes used in severe asthma exacerbations. And then things like muscarinic antagonists, corticosteroids, intravenous magnesium sulfate, and ketamine if severe.
Thanks, Maddie. So some of the important consideration, as you rightly mentioned, you have a very low threshold to move this patient to ICU because dealing pregnant patient on the ward can be quite challenging. So move her to ICU, establish some monitoring, including arterial line. And obviously, some of the examiners might expect, given that people who are appearing for fellowship exam immediately in March or April, talking about COVID pneumonitis might be relevant. So wearing the full PP while dealing with a pregnant patient who came with asthma exacerbation. So something to just think about. So let's move on to the second scenario, which is the 62-year-old male who is admitted to intensive care unit now 10 days ago with a diagnosis of acute pancreatitis. He's not tolerating his enteral feeding well. In the background history, he's a 30-pack-year smoker with a alcoholic intake of around 4 to 8 standard drinks per day. He is currently intubated and ventilated for last 6 days. And on ABG, he's demonstrating worsening gas exchange. So given the context and given the ongoing worsening gas exchange, what are your differential diagnoses and how will you address them?
So the differentials include complications related to his initial presenting complaint, so his acute pancreatitis, complications secondary to his ICU stay, or exacerbation of any chronic conditions that he might have. So from an acute pancreatitis point of view, this can be a multi-system disorder. So you can have cardiac complications. So it could be a SIRS-associated cardiomyopathy or a SIRS response with capillary leak. From a respiratory perspective, he could have ARDS, he could have pleural effusions, pulmonary edema, or chylothorax. From a gastrointestinal perspective, he could have pancreatic ascites, he could have abdominal compartment syndrome, could be an ileus, like he's not tolerating his feeds with worsening gastric distension, or it could be localized complications such as pancreatic necrosis. And from a renal perspective, he could develop acute renal failure and fluid overload secondary to that. From his ICU stay, it could be iatrogenic fluid overload. He could have got a nosocomial infection, such as pneumonia. He could have barotrauma, such as a pneumothorax, or could have atelectasis. He could have a PE from being in hospital and his acute state, or new pathology such as an AMI, or it could be delirium or agitation with ventilator dysynchrony and biting on the tube. From an exacerbation of chronic conditions perspective, he could have exacerbation of COPD, given he has significant smoking history. He could have alcohol withdrawal, but it's quite late in the piece for that. And he could have decompensated liver failure from his significant alcohol intake, or exacerbation of a pre-existing cardiac failure.
Yeah, that's a quite comprehensive list of differentials, Maddie. So how would you assess him?
So assessment would involve a history, examination, and investigations. So from a history perspective, it would look at his background, his chronic conditions, whether he has diagnosis of things like COPD, and whether that's well controlled, or any cardiac or liver involvement, like an alcoholic cardiomyopathy or liver failure, whether he's on any medications such as diuretics, inhalers, or steroids, and his trajectory in ICU, such as why he was intubated to begin with, his fluid balance, his recent vital trends, including any signs of infection such as Vivas, any recent investigations performed such as organ function and the trend, whether this was getting worse, any recent micro or recent imaging to look at complications from his pancreatitis. From an examination point of view, it would look at his vital signs, including an end-tidal CO2 and the trace, to look for things like evidence of bronchospasm, his secretion load, his level of sedation or paralysis and his neurological function, and his level of respiratory support on the ventilator and whether this has changed. It involved auscultation to look for any localized signs of infection or fluid overload, and looking at his abdomen to assess for distension, any drains that were present, and doing an intra-abdominal pressure, and looking at his fluid status and the urine output. Investigations would involve bedside tests such as an ECG to look at signs of new ischemia, a UA as part of a septic screen, considering an echo to look at his cardiac function, and ABG for gas exchange. Bloods would involve a septic screen, biochemistry, and looking at end organ functions with UEC and LFTs, and looking at inflammatory markers. And imaging would involve first a chest X-ray to assess for any changes on the chest X-ray and his tube position, and a low threshold for a CT, given his severe pancreatitis and 10-day stay.
Now, when you examine the patient, you see that there is a significant abdominal distension, and you ask your junior registrar to measure his intra-abdominal pressure. The registrar asks you, how would you measure the intra-abdominal pressure?
So there's guidelines for measurement from the World Society of Abdominal Compartment Syndrome, and they suggest that this is done in end expiration in a supine position with abdominal muscle contractions absent. So ideally the patient paralyzed. The transducer is zeroed at the iliac crest in the mid-axillary line, and then non-compressible tubing and a transducer is connected to an indwelling IDC. The bladder is emptied and clamped, and 25 mils of saline is introduced into the bladder. Then wait a minute, and a reading is obtained after that point to allow the detrusor muscle to relax. Confounders include patient-related things like increased pelvic pressure, high detrusor tone, incomplete paralysis, a pelvic hematoma, or chronic cystitis, or measurement-related, such as if there's problems with the transducer itself or improper setup.
Thanks, Maddie. So one of the differential that you mentioned is about abdominal compartment syndrome. What is it?
So abdominal compartment syndrome is a sustained intra-abdominal pressure of greater than 20 millimeters of mercury with or without an abdominal perfusion pressure of less than 60 millimeters of mercury that is associated with new organ dysfunction or failure. So this can be primary, so originating from intra-abdominal pathology, or secondary, originating from extra-abdominal pathology. And there are many risk factors for abdominal compartment syndrome, which include intra-abdominal pathologies such as trauma, massive hemorrhage, retroperitoneal hematoma, or pancreatitis, or treatment-related such as laparoscopy with high insufflation pressures, peritoneal dialysis, massive transfusion, or prone positioning, or other risk factors include high BMI or sepsis.
Okay. And what are the consequences of abdominal compartment syndrome?
So abdominal compartment syndrome can affect all the organ systems. So respiratory-wise, you can get decreased compliance, increased peak airway pressures, increased VQ mismatch and intrapulmonary shunt, atelectasis and pneumonia. From a cardiovascular perspective, because of the raised intra-abdominal pressure, you can get decreased preload and hypotension, and you can get increased afterload and decreased right ventricular output due to raised intrathoracic pressure. You can also get increased CVP and left ventricle and diastolic pressure and reduced compliance. From a neurological perspective, it can cause increased intracranial pressure. It can cause renal failure, and gastrointestinally, it can cause mesenteric ischemia, bacterial translocation, portal vein thrombosis, ileus, and decreased gastric emptying and feed intolerance, like this gentleman has. And from a hematological perspective, it can cause lower limb venous thrombosis.
Great. So can you please briefly outline the management principles of abdominal compartment syndrome?
So the management principles that can be divided into improving abdominal wall compliance, evacuating any intraluminal contents, evacuating any abdominal fluid collections, correcting positive fluid balance, organ support, and surgical decompression. So improving abdominal wall compliance involves heavy sedation and analgesia and paralysis, and avoid raising the head of the bed too far, although usually we do like greater than 30 degrees. In terms of evacuating intraluminal contents, you can do nasogastric decompression, rectal decompression, and prokinetics. From evacuating the abdominal fluid collections, this would involve things like paracentesis and percutaneous drainage, correcting positive fluid balance, avoiding excess fluids, using things like diuretics and potentially hemodialysis. And from organ support perspective, optimizing ventilation, titrating PEEP, so avoiding excessive PEEP, and trying to maintain an abdominal perfusion pressure of greater than 60. And surgical decompression involves things like decompressive laparotomies and temporary abdominal closures.
Thanks. So that's the end of our second scenario. So we'll move on to the third and last scenario of this podcast. So there is a 70-year-old female who is presented to ED with altered conscious state and a left-sided weakness. She is intubated and her blood pressure on the monitor shows reading of 240 over 120 millimeters of mercury. She had a background history of ischemic heart disease and AF. And when you perform the CT brain, it demonstrates a large right-sided temporoparietal intracranial hemorrhage with intraventricular extension. So what are your initial management priorities in this lady?
So my management priorities would involve a targeted assessment, including a history exam and investigations, and then consideration about the logistics, specific management and supportive management. From a targeted assessment point of view, the history would involve brief details about the presentation, so whether there was any trauma involved, the syncope or vomiting or seizures. In terms of her comorbidities, from an AF perspective, if she's on any anticoagulation that needs to be reversed, and from an ischemic heart disease perspective, if she's on any antiplatelets, whether she has any known intracranial pathology such as malignancy, her baseline function, and whether she has any known hypertension, and if so, how is it controlled? And then briefly about her medications, including anticoagulants, allergies, and social support. From an examination perspective, it involved looking at her GCS, pupils, and any signs of other trauma. And investigations would look at bedside tests such as an ECG for arrhythmias, an ABG for gas exchange and quick electrolytes and BSL, bloods, including her full blood count for platelets and hemoglobin, her coagulation, root group and hold, and consider things like a rotum. From an imaging perspective, looking at the chest X-ray for a tube and NG position and considering further imaging such as a CTA or an MRI if there are concerns regarding an underlying vascular lesion or mass. From an immediate management perspective, I need to think about the logistics involved. So having adequate monitoring and access for this patient, including full cardiac monitoring and an arterial line and adequate IV access. And she would need a bed in a neurosurgical ICU or a transfer to a neurosurgical unit. So it would depend on the hospital that I was in at the time. From a specific perspective, I'd like her blood pressure to be better controlled. So use short-acting IV agents such as hydralazine immediately and aiming a systolic BP of around 140 millimeters of mercury. Getting neurosurgical input, such as whether there was any neurosurgical options, such as for an EVD or evacuation of the hematoma. General neuroprotective measures, such as avoiding fever, normoglycemia, normoxia, and normocapnia. Reversal of any anticoagulation if present. And then from a supportive perspective, making sure that things like the ETT is in an adequate position, she's adequately analgesed and sedated for it. She has a good organ support with lung protective ventilation and social support, so notifying the family.
Yeah, that's important. Now, what is the evidence of acute blood pressure management in the context of hemorrhagic stroke?
So this is a controversial area and there's no firm consensus, but Australian clinical guidelines recommend that the target systolic blood pressure be acutely reduced to around 140 millimeters of mercury, but not much more in those with intracerebral hemorrhage. But they do acknowledge that this is based on weak evidence. Same with the NICE UK guidelines also recommend aiming for a systolic blood pressure of below 140 within 2 hours of starting treatment and maintaining this for at least 7 days. But this is in patients who present within 6 hours of symptoms and have a systolic of 150 to 220 millimeters of mercury. And then they said to try and consider achieving these targets in a more controlled fashion in those who present with a systolic of greater than 220. The American Heart Association also recommends similar, so targeting a systolic blood pressure of less than 140 in those with an initial systolic of 150 to 220. So the two main trials that all these guidelines are based on acute blood pressure control in acute hemorrhagic strokes are the ATTACH-2 trial from 2016 and the INTERACT-2 trial from 2015. So ATTACH-2 was a multi-center RCT that compared rapid lowering of systolic blood pressure to 110 to 139 millimeters of mercury versus 140 to 179 millimeters of mercury in hypertensive adults with an acute intracerebral hemorrhage. It found, though, that there was no difference in modified Rankin score of 4 to 6, which is death or severe disability, at 3 months, and no significant difference in other secondary outcomes, except for a high incidence of renal adverse effects within 7 days in the intensive treatment arm. INTERACT-2 compared intensive blood pressure lowering with similar targets, so less than 140, and compared that to less than 180 millimeters of mercury, and found that there was no difference in death or severe disability between the two groups. They did an ordinal analysis of modified Rankin scores, which indicated improved functional outcomes with intensive blood pressure management, with the best outcomes for the 130 to 139 millimeter mercury group over 24 hours. So I think that's where a lot of our guidelines are based on. But however, there's no firm consensus on the optimal blood pressure targets, and so they need to be individualized for the patient. Currently, there is weak evidence that a blood pressure target of around 140 is generally safe. And there's also some signal that recurrent excessive blood pressure fluctuations may predict poor clinical outcomes. So it's important, regardless what threshold we choose, that we closely monitor the blood pressure and avoid rapid swings.
Yeah, I think that's the important point, because I guess there are two key issues here. One is avoiding big swings in the blood pressure. So bringing blood pressure from 220 to 140 and then going again at 180, 190, that's not good. So I think the gradual reduction in the blood pressure, that's the main thing. And once you achieve the target, then making sure that the blood pressure remains in that target range, that's the crucial thing. Because the counter argument is if you lower the blood pressure too quickly, then obviously the patient will be at risk of developing ischemic event. And that's not good either. So it's always striking the balance. So gradual reduction. And once you achieve the target, then making sure that patient stays in that target range for the next 24 hours. That's the kind of key message. Now, this scenario can obviously go anywhere from this point in time, but I guess one of the commonly asked controversy in this area is around if this patient starts developing the signs of intracranial hypertension and persistently high ICP despite medical management, will you offer a decompressive craniectomy to this patient? And what will be your approach to that discussion?
So I think it depends on a few things. So like her function, she's 70 and she's already got ischemic heart disease and AF. So what her functional status is like and her baseline function, but also decompressive craniectomies has a very limited evidence base in the intracranial hemorrhage population. It would be, I think, different if she was younger and it was like a malignant MCA infarct. So I think if the hemorrhage were to progress to a point where she required a decompressive craniectomy, I think her outcome would likely be very poor. So I think it'd be a collegiate discussion and involve a multidisciplinary approach, but I'd be leaning away from offering that.
Yeah, that's it. That's correct. And also, I think sometimes considering the patient's wishes are important, because even if you offer decompressive craniectomy, the most likely outcome that patient will be left with severe disability. So that's not going to be a good outcome for this patient. So it might save life, but obviously patient will be left with significant disability. You're right. You as an intensivist, you will probably stay away from offering the decompressive craniectomy in this particular patient. And then the other things, there are important controversy that people or the candidates should think about, because patients has got a history of AF. Managing the AF without anticoagulation will be challenging. So obviously patient will be at risk of developing more thrombotic complications, because patient will not be suitable for any anticoagulation for long period of time. And then patient does progress to brain death, then I guess the question will be around the donation processes. So there are some of the kind of ramifications of this scenario from this point in time. So just some food for thought for.
I think the other thing with this is that it can go towards is about if she was on antiplatelets and whether you'd give her platelets beforehand.
In my practice, I often see that neurosurgery will not take to this patient to theater unless you administer at least 2 pooled platelet when the patient was on an aspirin. So there is a bit of disconnect in the guidelines and actual practice that we observe in hospitals. So there is that kind of variability with each neurosurgeon, because most of the guidelines are based on a very weak evidence.
Yeah, I think, but if people are interested, if they check out the PATCH trial, I think that's where a lot of our evidence now comes from for antiplatelets in this situation.
That's correct. So thanks, Maddie. So that's the end of our podcast. Do you have any other final thoughts?
Oh, yeah, always. Okay, so I've got one. But what is Mylan's favorite ballet? Like Mylan, like the coverage of nerve.
So you're asking about Mylan's favorite ballet?
Yeah.
Like Milo?
No. Swan Lake.
Oh my goodness, Maddie. This was a hard one, actually. I don't think I would have got this. Listeners, if you want to access Maddie's show notes, they are available on website www.critcareedu.com.au. So make sure that you access these notes, because they will be very useful for your exam preparations. So thanks again, and see you in months' time.
Thanks for listening. See you next time.